Good morning, everybody. Welcome to the Calium Reentry Initiative Learning Collaborative. Today, we're going to be talking about pharmacy policy. Before we jump into our agenda for this morning, wanted to remind folks that your microphones will be muted while while the presenters are speaking. We do want to take your questions though throughout the presentation. So please, as usual, use the Q&A feature to share feedback or ask questions. We'll have people monitoring the Q&A and providing responses throughout. Whatever questions don't get answered today, we'll make sure that we follow up. But we're really excited to be wrapping up the first part of our Learning Collaborative series with today's session on pharmacy policy. So let's go ahead and jump in and get started. Next. As you all probably know, my name is Autumn Boylan, and I am with the California Department of Healthcare Services. I oversee the team leading the Justice Involved Reentry Initiative. And we're really fortunate today to have my colleagues from our Pharmacy Benefits Division joining us to share more information about the Medi-Cal Rx pharmacy policy as it applies to the Reentry Initiative. On the next slide, you'll see my team structure, as you've seen in all of these prior sessions. And on the slide after that, you'll see the structure of our Pharmacy Benefits Division. We have Erica Holmes as our interim chief. I don't believe she'll be joining us today, but Erica Skye, who's been working with us from the beginning from our Pharmacy Benefits team and is the lead for pharmacy on the Justice Involved Initiative, will be joining us along with her team, Sylvana Ho and James Gaspar. So we're really excited to have folks joining us today. We have some other speakers from some of our partner organizations that will be joining us as well. But want to make sure that you're getting a chance to get to know our teams behind the scenes. Next. Now, as usual, we'd like to know who's here with us today. So please go ahead and click on the poll and let us know if you're representing a county jail, youth correctional facility, county behavioral health, managed care plan, provider organization. Just choose the option that best describes your organization so that we can get a sense of who is joining us today. I see that we have about 13 or 14% of our participants today are from county jails, about 5% from our county youth correctional facilities, about 23% from our county behavioral health agencies. So lots of folks joining in. We've got folks from our county sheriff's offices, reentry providers, managed care plans, and a lot of folks who are identifying as others. So thank you all for joining today. This information that we gather in each of these calls has been super helpful to us as we think about how we're disseminating important information to all of our implementation partners. And we're glad to know that you're here with us today. So thank you so much for completing the poll. So over the last several months, we have been, you could go to the next slide, please. We have been going through our learning collaborative process. So we started in August with a kickoff. We talked a lot in that session about provider enrollment and some of the requirements related to that, generally introduced the reentry initiative, kind of got these conversations started to help build bridges across implementation teams from county jails to youth correctional facilities to managed care plans and our state prison partners as well. And then we continued the series in September, diving deeper into the screening portal and the short-term model, talking about behavioral health services and behavioral health links in our September 26th session. Really went deep on physical health, clinical consultation, and explored some journeys of potential illustrative patients and what that might look like in terms of billing and claiming for physical health clinical consultation services. And then in November, spent some time talking about enhanced care management and the warm handoff. And we're lucky enough to have some really exciting speakers from Transitions Care Network and Amity Foundation to join us for that session. Today marks the last of this first part of our Learning Collaborative series, but we absolutely will launch part 2 of the Learning Collaborative series in January. And really start to go deeper on other types of topics that will help with implementation across this initiative and for our program partners. We might talk about things like patient engagement in care, data sharing authorization, guidance. And I do also want to flag there that there is a reentry toolkit that was recently shared out. We'll send it out to all of the participants for today's meeting, as well as our contact list, to get input on our data sharing reentry toolkit. So we'll go deeper into that in a future learning collaborative session as well. We're also going to be sending out a survey to all of you to get your input on what topics might be the most beneficial and which topics that we already covered would you like for us to revisit. So I just wanted to highlight what's coming up. We'll talk about that again at the end of today's session as well. But we've done a lot of work together, and if you missed any of these sessions, feel free to reach out to us and we'll provide the materials and resources from each of these meetings. Next. As usual, we have our collective working norms. I think that we've been working really well together, so we'll continue to adhere to these principles that you all collectively contributed to for these groups. I think the dialogue and discussion, the questions that you've been asking has been rich and meaningful, and really aligned with our collective working norms. So appreciate everyone's kind of bringing curiosity to these sessions, bringing your questions to these sessions, and being willing to share. Particularly want to give a shout out to the 3 counties that went live or were approved to go live in October, Santa Clara, Yuba, and Inyo, who've been very generous with your time and sharing and helping other counties understand what it is that you're doing in your county. So really appreciative of kind of the willingness to bring some of those conversations and be transparent with you all so that we can collectively work together to implement this initiative statewide. Next. So the last session, as I said, we really dug into the ECM benefit for the JI population of focus. We talked about supporting implementation for pre-release care management services, care management models, the mixed model, embedded model, and in-reach models. We talked about care manager assignment processes, the expectations for the reentry period and warm handoff. We did share information about the MCP auto assignment process so that we can make sure that there are no gaps in terms of coverage for individuals who are receiving pre-release services that can get automatically assigned to a managed care plan, and that being activated as close as possible to the release date. We talked about some best practices for engaging the reentry population and heard from some of our provider organizations that are doing that so well in the community, and thinking about how we can translate some of those best practices into our pre-release services delivery infrastructure. And then we heard from our county partners in terms of what it is that they're doing to start to develop best practices to facilitate collaboration with managed care plans, and really how they are figuring out this process of the pre and post release care management and warm handoff pieces. So it was a great session. And again, we're grateful to our county partners who continue to just share, as we're going to hear in today's session as well. Next. And so for today, we're going to talk about pharmacy policy. We know that particularly in the beginning, this is an area of the policy and operations guide where we got probably the most questions around the pharmacy policy, about the medications in hand requirement, about coverage for SUD services in terms of medication. And there's been a lot of questions. So we're going to dive deep into our pharmacy policy. We're going to hear again from Santa Clara County, who's going to share with us information about their own provision of pharmacy services as part of their go live. And we're going to just really learn more about these requirements and what it's going to take to implement it. So I'm really excited to introduce you to our pharmacy benefits team. And I'm going to turn it over to Erica Sky, again, our lead for the JI Pharmacy Policy Team with our Pharmacy Benefits Division here at DHCS. Erica?
Thanks, Autumn. So yes, I'm on the pharmacy benefits team here at DHCS. Prior to that, I worked many years in correctional healthcare. So I'm happy to be with you all today. Next slide. So to kind of level set the glossary of terms for this meeting, disposable medical supplies are those single-use disposable medical supplies required for medical necessity and used by a member to mitigate or ameliorate a medical condition in a member's home. They're products that are commonly found in pharmacies. Examples are diabetic supplies, enteral nutrition products, and insulin fusion pumps. And then separate from that are durable medical equipment, and that's equipment used for medical reasons that can withstand repeated use, used by members to mitigate or ameliorate a medical condition. Examples for this would include walkers, canes, wheelchairs, and ventilators. So just want to distinguish the difference between the two for this conversation. And then providers in this presentation, we're using the term providers to refer to pharmacy providers. And prescribers would be used to refer to clinicians with prescribing authority. And then a contracted pharmacy is, in this presentation is, sorry, my screen doesn't go all the way. Contracted pharmacies refer to licensed community-based or out-of-state pharmacy that is contracted with correctional facilities and enrolled in Medi-Cal to provide for this purpose. Next slide, please. To the presenter, my screen is cutting off the bottom of the slides. If you can minimize it. Let's see, maybe I can change my view. Okay. So pre and post-release medication, disposable medical supply delivery. The justice involved reentry demonstration allows medications, disposable medical supplies to be provided in the 90-day period prior to the expected date of release, including medications for substance use disorder and for a supply of medications, disposable medical supplies to be provided in hand upon release with prescriptions for refills in place to ensure continuation of treatment plans. Medications, disposable medical supplies during the pre-release period, the in hand upon release period, and the disposable medical supplies for following release. And if the correctional facilities do not have infrastructure and processes to support the dispensing of medication and disposable medical supplies during the pre-release period and on the day of the release, they need to provide an action plan to support that. Next slide, please. Medications and the reentry initiative. Medications during the pre and post-release periods are a critical component of the Justice Involved Reentry Initiative. Medications and medication administration must be provided consistent with the state plan. The core objectives of the medication services is to ensure access to medications that are traditionally difficult to obtain in CS, such as long-acting injectables, stabilization of individuals with chronic conditions and behavioral health needs on medications prior to release so that their conditions are well controlled during the immediate post-release period. As we know, that's very important. And to provide medications upon discharge with prescriptions for refills to ensure there is no gap in access to critical medications. Next slide, please. So for the pharmacy enrollment and processing requirements, we'll be talking about that next. All medications, disposable medical supplies dispensed during the pre-release period or upon reentry must be dispensed from a licensed, registered, Medi-Cal enrolled outpatient pharmacy following all state and federal laws. To provide medications in the pre-release period and upon reentry, CF must ensure the use of a licensed, registered, Medi-Cal enrolled pharmacy to dispense covered outpatient pharmacy medications, specific medical supplies, and/or enteral nutrition products. The submission of pharmacy claims through Medi-Cal Rx, that's our system here, and the support of prior authorization processes for any medications or disposable medical supplies requiring a PA. DHCS requires on-site pharmacies, contracted out-of-state pharmacies, or contracted community-based off-site pharmacies to be enrolled in Medi-Cal and billed through the Medi-Cal Rx system. Next slide, please. The following entities can provide medications in the 90-day period prior to the expected date of release, and a supply of medications in hand upon release with prescriptions for refills. Each of these entities must be enrolled, as we said, in as a Medi-Cal pharmacy through PAVE to administer medications in the pre-release period and upon release. Any jail, youth correctional facility, or prison facility with a licensed outpatient pharmacy on site, or any licensed outpatient pharmacy located in or out of state that is contracted with Medi-Cal to provide prescription services. And the pharmacy enrollment will be location specific. If your location has multiple on-site pharmacies, only one pharmacy per site is required to enroll. And there's a link for more information there. And the expectations for utilizing Medi-Cal Rx. The Medi-Cal Rx system is designed to ensure pharmacy benefits are compliant with state and federal laws. Medi-Cal Rx adjudicates pharmacy claims, reviews pharmacy prior authorization requests for medical necessity, and provides technical support as needed. Per federal and state laws, the pharmacy that dispenses the medications is responsible for the billing through Medi-Cal Rx. The pharmacy may use a third-party administrator to submit claims, but the claims must be submitted under the NPI of the pharmacy that dispensed the medication. Important things to note there. Prior authorization requests. CFs and contracted Medi-Cal enrolled pharmacies are expected to comply with existing Medi-Cal prior authorization requirements. Medi-Cal Rx accepts and processes PAs and provides a response to the submitting Medi-Cal provider within 24 hours of receiving their request, or next business day if the request is received after hours, pursuant to applicable state law. Just a note here, some counties and correctional facilities are using the pricing agreements through the Department of General Services for some of their medications. And for those that are doing so, they must adhere to the terms of the DGS pricing agreement, uphold objectives and minimum requirements of JI, may include transferring prescriptions for JI eligible members to a Medi-Cal enrolled community or mail order pharmacy, maintain separate stock either virtually or physically, or submit claims to Medi-Cal only for the non-DGS drugs. Billing for Medi-Cal Rx is prohibited for the DGS purchased drugs, and all CFs must attest they will not bill Medi-Cal for any drug that was purchased through a DGS pricing agreement. We've established guidance for the facilities on how to potentially deal with this issue, and there's more information we can send to you if you are looking for that guidance, so please reach out. All right, medications and disposable medical supply coverage during the pre-release period. Next slide. Dispensing patient-specific medications in the pre-release period. So CF pharmacies and/or their contracted pharmacies will be able to seek reimbursement through Medi-Cal Rx for any medications covered by the Medi-Cal Rx, mostly without PA requirements. The contract drug list includes a wide array of medications for the full range of acute and chronic conditions. I'm going to pull up my pronunciation key here. Ciprofloxacin for infections, abacavir sulfate for HIV, and Zipatir for hepatitis C. Yes, I practiced, but still needed the key there. The Medi-Cal contracted drug list can be found on our website at the link there. And DHCS expects there will be some differences between drugs listed in the Medi-Cal contract drug list and the drugs currently used by CFs under their existing formularies. So we'll work with you to identify and minimize any gaps by supporting the identification of alternative medications that CFs can provide in lieu of those that are currently being used, but do require a PA. We don't want the PA burden to be, a heavy lift for you all. So thank you. Next slide. DHCS is aware that some CFs may dispense a subset of their medications to individuals from a shared stock. For example, by distributing medications from a non-patient-specific bottle to multiple patients based on patient-specific orders. So DHCS encourages CFs to change as many medications as possible over to prescriptions dispensed from the pharmacy in patient-specific containers for billing purposes. However, the department understands this may not be possible for all medications, and a subset may still be dispensed from a shared stock. DHCS will require all medications provided in a non-patient specific manner, meeting the categories listed below, to be billed to Medi-Cal fee-for-service via the California Medicaid Management Information System, also known as CAMIS, instead of Medi-Cal Rx. So all medications with existing HCPCS codes for drug-specific administration, any medication for SUD except for methadone, and all injectables, including those without an existing drug-specific HCPCS code. All right, next slide, please. In most cases, medications will be billed through Medi-Cal Rx. Requirements for Medi-Cal Rx will be discussed later in this presentation. For a subset of medications, including administration for medications dispensed from shared stock, CFs can also submit claims to CAMIS. Examples of Medi-Cal Rx and CAMIS covered items are found in the links below. So our Medi-Cal Rx contracted drug list and the DME and medical supplies provider manual. And more information in the links below. Next slide, please. So medications and disposable medical supplies and prescription refills upon release. The Justice Involved Reentry Initiative includes the provision of medications in hand to eligible individuals released from a correctional setting. The primary goal of administering medications in hand upon release include ensuring individuals have access to a sufficient amount of medication to follow their treatment plans, maintaining stabilization on the medications the individual was prescribed while incarcerated, and avoiding decompensation in the period between release and any appointments the individual may have with their community-based physical and/or behavioral health partner. So just trying to bridge that gap on the way out into the community. Next slide, please. DHCS has set forth the following minimum requirements for CFs to ensure the necessary processes and partnerships are in place to provide medications in hand upon release. Minimum requirement number 1, provide a full supply of medications in hand upon release with prescriptions for refills in place as clinically appropriate. Number 2, use of Medi-Cal enrolled pharmacy and compliance with existing Medi-Cal rules. Number 3, comply with Medi-Cal's prior auth and utilization management requirements. And number 4, overdose prevention, provide naloxone upon release and clinically appropriate supply of medications for SUD with follow-up. Next slide, thank you. Description of medications upon release requirement. CFs are required to provide a full supply of all active medications in hand upon release to incarcerated individuals receiving pre-release services with prescriptions for refills in place as clinically appropriate. So please note the full supply is defined as a maximum amount that is medically appropriate and allowed by the state Medi-Cal state plan, which under most cases is up to 35-day supply for controlled substances and 100-day supply for other prescription drugs. At a minimum, CFs are required to develop processes for providing prescribed medications in hand upon release for those with an active JI aid code within 48 hours. The CF should also submit a prescription for any active medications to a community pharmacy. A supply of medications and access to refills will allow the individual sufficient time to establish relationships with their community partners. And requirements for discharge planning are there at the bottom. During the discharge process, the pre-release services care manager will be responsible for developing a list of active and discontinued medications that will be provided to an individual upon release. This list should include the name of the individual, dosage of all medications, and the name of the dispensing pharmacy. And that the pre-release services care manager will also work with the post-release care manager if different to coordinate. Next slide, please. All right. Minimum requirement number 2, use of a Medi-Cal enrolled pharmacy. Description of pharmacy enrollment requirements. CFs are required to obtain medications from a Medi-Cal enrolled pharmacy using all standard Medi-Cal Rx processes for prescriptions to be paid under the JI initiative. Any CFs that currently do not have a Medi-Cal enrolled pharmacy are required to enroll their pharmacy as a Medi-Cal provider or contract with a Medi-Cal enrolled pharmacy vendor or obtain medications from a Medi-Cal enrolled community or mail-in pharmacy. And all the CFs are required to ensure that all prescription medications provided upon release are billed and claimed through Medi-Cal as well. And then electronic prescriptions. Without an electronic prescription sharing system through electronic health records between CFs and pharmacies, sending prescriptions electronically will not be possible. While paper, fax, and phone applications will be the norm initially, DHCS does expect that electronic prescriptions will become the standard as we continue to build those information exchanges. And then DHCS also understands there'll be operational complexities for individuals leaving prison who do not have established residence pharmacies. So DHCS does not expect the same operational complexities to exist for those with shorter stays who have pre-existing relationships with outpatient pharmacies and established residents. Next slide, please. So requirement number 3, compliance with PA and UM requirements. Establishing claim and PA history during the 90-day pre-release period is crucial in supporting an individual's transition into the community so they do not have difficulty obtaining their medications upon release. Claims submitted to Medi-Cal Rx for drugs and disposable medical supplies are subject to claim edits, including age limits, labeler restrictions, and quantity limits, which may require authorization by Medi-Cal Rx before reimbursement can be provided. And then for medications and supplies requiring a PA, Medi-Cal Rx accepts and processes PAs and provides a response to the submitting Medi-Cal provider within 24 hours of receiving the PA, and like we said, as or next business day if the request is received after hours. And the pre-release services care manager is responsible for supporting the submission of PAs and coordinating with the Medi-Cal pharmacy to ensure medications are available for provision upon release. Through this process, the individuals will have received prior authorization for needed medications, facilitating that continuity of care and minimizing the burden of receiving prior auths prior to release. Note there'll be several ways to submit the PA requests, and those are the ways there on the screen. We accept them via NCPDP, and the Medi-Cal Rx provider portal, Cover My Meds, fax, and US mail. Next slide, please. Description of clinically appropriate supplies for medication for SUD with follow-up. At the time of their release, all individuals must be offered naloxone and instruction on its use, regardless of any prior history with opioid use disorder. Naloxone is a Medi-Cal covered drug, and many CFs currently provide group training on naloxone to those in custody. That may not be new to a lot of you. The distribution of naloxone was identified as a best practice through conversations with implementing partners during the JI advisory group meetings. And for individuals with OUD, CS, and pre-release care managers should also ensure access to opioid treatment and any additional resources at their time of their release. CS should provide individuals as medically indicated by a provider with medications for SUD at the time of release and facilitate follow-up appointments in the form of warm handoffs and/or behavioral health links with community providers. Long-acting injectables should also be considered just prior to release with some evidence of improved outcomes using this form of MAT. And then a note below about dispensing naloxone without a prescription that's already being done by pharmacists. And next slide, please. And then the medication for substance use disorder coverage. As part of Reentry, CS must provide medications for opioid use disorder and other medications for the treatment of SUD. The goals of providing medication for SUD are to cover and promote all medications for the treatment of SUD available in Medi-Cal RX, expand and ensure access to medications for SUD for pregnant and postpartum individuals, expand access to concurrent behavioral health care, ensure that opioid overdose reversal medications like naloxone is available and staff have been trained how to use it, ensure continuity of care by providing an adequate supply of medications specific to each patient's needs, and then the policy rationale there from the Department of Justice about opioid use disorder being a disability. Next slide. DHCS strongly supports the use of evidence-based screening for potential SUD as part of any carceral intake. SUD screening should include the below: prior SUD treatment and diagnoses, need for SUD-related clinical consultations, identification of any SUD medications while incarcerated or upon release, identification of potential benefit for long-acting injectable use for SUD, identification of the need for behavioral health links for county-based behavioral health services, identification of need for SUD follow-up and appropriate level of care, and then the screening results from validated screening tools, such as the TCU DS5, the ASIST, and the SSI, and then a note below about screening expectations for short-term stays. Next slide. CFs are responsible for initiating and providing medications for SUD as soon as the need is identified via screening. Individuals must meet the eligibility requirements to receive services. So individuals eligible for SUD treatment must meet the criteria for a SUD as defined in the current editions of the DSM or the International Statistical Classification of Diseases and Related Health Problems, or have a suspected SUD diagnosis that is currently being assessed through either the NIDA modified or the ASIST or the ASAM criteria. Next slide. All non-residential SUD treatment services are eligible for Medi-Cal Medi-Cal reimbursement during the 90-day period prior to release. And then the below outlines requirements for the treatment. It includes assessment of individuals who screen positive for SUD, treatment planning, timely introduction of medication-based treatment, timely continuation of medication prescribed in the community, tapering or discontinuation of medications, policies and procedures to support evidence-based treatment, and services and placement in non-residential levels of care. And the full list of DHCS treatment requirements for opioid use disorder and alcohol use disorder can be found in the Policy and Operations Guide, section 8.7. Next slide, please. Treatment for opioid use disorder has additional requirements. The requirements are outlined below. Assessment of individuals who screen positive for OUD. Treatment planning consistent with Medi-Cal requirements. Management of opioid withdrawal with agonist medications, either methadone or buprenorphine, using evidence-based tools and interventions, timely induction of an appropriate form of medication based on the individual's preferences for agonist or anti-agonist treatment, timely continuation of any agonist medication prescribed in the community for the duration of incarceration, and policies and procedures to support evidence-based treatment of OUD is accessible to pregnant and postpartum individuals. Next slide. So treatment requirements continue tapering or discontinuation determined by both the clinician and the patient on a case-by-case basis. Services and placement in non-residential levels of care, if available within the CF, as determined by the full ASAM criteria assessment. Examples of evidence-based practices that may be provided as part of non-residential SUD treatment include motivational interviewing, CBT, peer support services, psychoeducation, and maintenance of continuity of care by transitioning to community providers through close coordination with the pre- and post-release care managers. Providing an appropriate supply of medications in hand upon release with prescription refills in place as clinically appropriate. Next slide, please. And then technical assistance for SUD treatment. To support increased access to treatment for SUD in CFs, DHCS will provide technical assistance to facilities. Technical assistance will be targeted to deepen CF providers' understanding of legal and regulatory requirements. In addition to technical assistance, JI PATH funding will be available to CFs and can be leveraged to establish or update existing treatment services to meet DHCS requirements, support CFs and their vendors in becoming Medi-Cal enrolled providers or NTPs, and develop contracts with NTPs or community-based addiction treatment providers. Next slide. Medication coverage for short-term stays. We know these are challenging, and we understand that many individuals have unknown release dates at the time of incarceration. DHCS developed a short-term model that provides timelines for when facilities should start providing pre-release services and anchors the provision of services around the date of incarceration and JI aid code activation. So the minimum requirements are all CFs are responsible for providing medications as soon as the need is identified. Identifying needed medications and prescriptions can be based on any need identified through standard medical screening procedures. Claims for medication and medication administration, including those for SUD, should be submitted for dates of service within 8 days of aid code activation. CFs are also responsible for preparing written prescriptions and providing prescribed medications in hand upon release for those individuals. And then recommended implementation practices. CF should determine the needed medications for an individual, including SUD, during the initial intake process within 24 hours of incarceration. If an individual has previously been incarcerated, the CF should leverage previous medical records to ensure the necessary medications can be provided in hand upon release. And then CF should work with the pre-release care manager to confirm medications provided while incarcerated will be available in the community upon release. Next slide. So we have a good list of resources for you for the JI initiative and contact information here. Please feel free to utilize all available resources and contact us whenever you need. Next slide, please.
All right, thank you so much, Erica. We have scheduled a little break. It's a little ahead of where we thought we might be, but we know that there are a few questions in the chat or Q&A. So we'll go ahead and address those. We'll give everybody a quick stretch break, and we'll come back at 10:50. It's 10:50. And when we come back, we're going to hear from our team around kind of the Medi-Cal RX system, and we'll dig into that before we hear from Santa Clara County about some of their experiences with implementing the pharmacy components of the initiative. So we'll give everybody until 10:50, and then we will come back. If you have questions, keep putting them in the Q&A, and we'll get busy answering them. Thank you, everybody. All right, welcome back, everybody. Thank you so much for coming back. We are going to continue with today's meeting, and we know that there are still questions in the Q&A. We're working on responses to those as we go. Some of the questions have been answered already, and so we will we'll continue to work on that in the background. All right, so now we'd like to introduce Jasmine Hicks, who will be talking about the billing process for pharmacy services. Jasmine, you want to come on and introduce yourself more fully, let folks know who you are and where you come from before you jump in?
Sure, definitely. Thank you so much, Autumn. I appreciate it. And good morning, everyone. My name is Jasmine Hicks. I work for Medi-Cal RX side as a senior training program specialist. And here today, calling from California, normally sunny, but definitely rainy, and enjoying that today. And we will go ahead and start our section today by talking about the billing processes. We're going to start by discussing the Medi-Cal RX public provider portal. Now, the Medi-Cal RX Public Provider Portal provides a suite of resources to ensure stakeholders have the tools that they need to successfully navigate and assist Medi-Cal RX members. Now, this website and resources are publicly available, and they do not require a login to access. Presently on the Medi-Cal RX Public Provider Portal is the Medi-Cal RX Contract Drugs List and Covered Products List, the Drug Lookup Tool, UAC, and a variety of other resources. We will discuss the CDL and covered products list in a little more detail in a later section. Now, the drug lookup tool is located in the tools and resources dropdown on the public provider portal and can be used to perform a quick search for covered products by name or NDC. Additionally, the tool informs the user if that product has prior authorization requirements or Code 1 restrictions. Additional details about these restrictions and requirements can be found on the Medi-Cal RX CDL and covered products list. Now, the user administrative counsel information is available to provide direction to providers on registering for Medi-Cal RX's secure provider portal, where information about finances, claims, and PAs can be found and changed. Lastly, the public provider portal has lots of other resources, such as useful forms, information on FDA recalls, and information on drug utilization reviews, and much more. Now, to stay up to date on all things Medi-Cal RX, allow these resources and new information to come directly to you by enrolling in the Medi-Cal RX subscription service. Next slide, please. Also within the Medi-Cal RX public provider portal, the Medi-Cal RX education and outreach page offers additional education information pharmacy providers and prescribers may deem useful. Now, the E&O page offers some brief background information on Medi-Cal RX and the standardized processes we have in place, as well as training materials for all things Medi-Cal RX, such as PA submissions, claim submissions, and finance. Additionally, providers can find a link to the Medi-Cal RX YouTube channel, which has a playlist of tutorials and webinars that are helpful to Medi-Cal RX providers and prescribers on similar subjects. Lastly, but just as important, the Bulletins and News page offers a suite of alerts and information that are important to Medi-Cal Rx pharmacy providers and prescribers. Now, let's turn our attention to tools and resources that are available to providers and prescribers on the Secured Provider Portal, which can be accessed after enrolling as a Medi-Cal Rx portal user via UAC. Next slide, please. Registered providers can log in and access various applications. Features on the Secured Medi-Cal Rx Provider Portal include the following. Now, under the Forms and Information tab, pharmacy providers and prescribers can access resources to assist with how to submit pharmacy claims, as well as how to manage and view prior authorizations. The Member Lookup tool is where to view and confirm eligibility and member details. Additionally, it includes access to the Finance portal, where pharmacy providers and prescribers can access payment explanations and much more. Under the Contact Us tab, pharmacy providers and prescribers have access to the Secured Messaging Center and Secure Chat. You can communicate directly with one of our customer service representatives there. And our learning management system, Cornerstone, is the platform where you can view the education and outreach events calendar, register for events, take online courses, and access resources. Here, you'll be able to sign up and enroll for future trainings and topics pertaining to Medi-Cal Rx. Next, let's move on to our next topic, which is the Medi-Cal Rx Provider Manual. Next slide, please. The Provider Manual is a comprehensive guide to Medi-Cal Rx to support pharmacy providers and prescribers. Now, the Provider Manual is located on the Medi-Cal Rx Provider Portal and can be found in the Tools and Resource dropdown. This manual covers all things Medi-Cal Rx, including our policies and procedures, information on covered products and restrictions, and information on PA and claim submission. In addition to these topics, the Medi-Cal Rx Provider Manual has sections on most topics as they relate to Medi-Cal Rx. When navigating in this document, we highly recommend using the table of contents so you can quickly navigate to the subject you're looking for. Now, it's important to note that the Provider Manual is a comprehensive document for stakeholders and should be reviewed for further information on any subject. Next, let's look at the Medi-Cal Rx covered products list. Next slide. To determine drug and product coverage, refer to the CDL and covered products list, both available on the Medi-Cal Rx Provider Portal under Forms and Information, which is updated monthly. These lists provide detailed information regarding drugs and products that are eligible for coverage and reimbursement under Medi-Cal Rx, including coverage restrictions, reducing the need for PAs. Please note that disposable outpatient medical supplies are a partial carve-out, and if it is not listed as a covered item on the Medi-Cal Rx web portal or in a covered list, the provider should bill the member's medical benefit. Additionally, members that have other healthcare coverage refer to that member's other health plan information regarding their respective covered products that are not included here. Next slide, please. The CDL is searchable by generic name and is alphabetized by therapeutic class. Drugs not found on the CDL require a prior authorization. Drugs and products found on the CDL are also subject to utilization management type code 1 restrictions, such as those you see here on the slide. Additionally, covered products may have quantity limits not listed on the CDL that are reflective of sound clinical practices and FDA-approved dosing. For more information regarding the CDLs and other covered products lists, as well as navigation and best practices, feel free to review the Medi-Cal Rx CDL and approved NDC list, our navigation video, which is located on our Medi-Cal Rx YouTube channel. Next up, let's discuss claim submission methods. Next slide. The available claim submission methods are point of sale or POS, web and batch, paper, and fax. Now, POS, web, and batch all follow NCPDP D.0 format per our Medi-Cal Rx payer sheet. Now, for more information on paper forms, refer to the Medi-Cal Rx Provider Manual. Now, POS system is the most efficient submission method due to its instantaneous submission capabilities. The web claim submission system is located in the secured provider portal. This also contains instant claim processing. Here, you can also view status, manage, and resubmit claims. Now, for batch claims, for pharmacies using batch processing, primarily need to use SFTP transmissions. Now, for record specifications and transmission requirements, pharmacies should visit the Medi-Cal Rx provider portal and then select forms and information to complete the batch claim processing form or contact the customer service center. Now, for paper claims, the claim turnaround is 7 to 10 business days, and paper claims must be submitted using one of the following forms: the Universal Claim Form, or UCF, Non-Compound Claim Form 30-1, or the Compound Claim Form 30-4 for compound forms. Now, all these forms can be found on the Medi-Cal Rx portal under Forms and Information. For further information regarding claim submission details, refer to the Medi-Cal Rx Provider Manual. Now, let's go ahead and take a look at some claim submission information. Next slide. Displayed here on your screen are the required elements for Medi-Cal Rx pharmacy claim submission. The BIN, PCN, and RX group are consistent for all Medi-Cal Rx members. The member ID will be specific to the member and can be found on their BIN or their HAT cards. Now, as a reminder, member eligibility can also be verified via the secured provider portal or by contacting our customer service center. Please note that the group submitted on the claim does not have any dashes nor spaces. So please be sure to submit exactly as it is displayed. Next, let's go ahead and look at timely filing limits. Next slide. For full reimbursement, a claim must be submitted and received within 6 months from the date of service. Claims submitted more than 6 months past the date of service and claims that are not received within the 6-month billing limit and do not have an approved exception will be reimbursed at a reduced rate or will be denied. Detailed information regarding timely filing limits can be found in Section 4.7 of the Medi-Cal Rx Provider Manual. Next, let's discuss how to submit prior authorization requests. Next slide, please. Certain pharmacy drug and medical supplies dispensed by a pharmacy are subject to authorization by Medi-Cal Rx before reimbursement can be approved. PA requests can be submitted via the 5 approved submission methods: NCPDP P4 transaction, Medi-Cal Rx secured provider portal, Cover My Meds, fax, and US mail. Prescribers may submit PA requests via the methods listed above, although NCPDP P4 transactions are submitted directly from the pharmacy using the POS system. Now, the pharmacy can submit and request a PA on behalf of the member or provider via Cover My Meds. Although pharmacy providers can initiate PA requests, CMM can only be submitted by a prescriber. Now, pharmacy providers and prescribers can reference the PA job aid found on the Medi-Cal Rx training tab within the Education and Outreach page located on the Medi-Cal Rx provider portal. Next slide, please. After submitting the PA request, it then goes into review, which will result in one of the following determinations: approval, approved with modifications, deferred, or denied. Medi-Cal Rx will ensure that PA requests are reviewed and the PA submitter receives notification of determination of the PA request within 24 hours. The PA submitter will receive a fax and/or correspondence communicating the PA request determination, except in the case of real-time approval via Cover My Meds. Now, for more information on the PA request process, including retroactive PAs and determination communication, refer to the Medi-Cal Rx Provider Manual, Section 14.0, Prior Authorization Request Overview. Next, let's go ahead and discuss some Medi-Cal Rx resources. Next slide, please. Here on your screen are some available Medi-Cal Rx resources, including just general Medi-Cal Rx resources, secured provider portal resources, pharmacy claim and PA resources, as well as the CDL. Next slide, please. Now, as previously mentioned, Further updates are published to the bulletins and news page. Now, allow these resources to come to you. Sign up for the Medi-Cal RX subscription service, and you can receive these alerts and updates directly to your inbox. You will not miss a thing. Next slide, please. We also encourage you to review our website and our resources. If you have any questions, you can email the E&O team at Medi-Cal RX Education Outreach at primetherapeutics.com if you have questions or if you need assistance. Also, our customer service center is available 24 hours a day, 7 days a week, 365 days a year to provide around-the-clock support. And that concludes the billing processes for pharmacy services. Thank you so much for your time. And Autumn, I will pass it back to you.
Thank you so much, Jasmine. Hopefully that was a helpful overview and introduction of the Medi-Cal RX billing infrastructure. Loved all of the resources there and how folks can stay in the know about the Medi-Cal RX policies. So thank you so much for sharing that. We are going to now transition from you hearing from us to now you hearing from our county partners in Santa Clara. We're pleased to be able to invite back, they've been very generous with their time, the Santa Clara County team, who will share some additional information with you all about their current system for providing pharmaceutical services to their Medi-Cal members, and excited to have folks here. So we have Oliver Sue and Allison May from our Custody Health Pharmacy team in Santa Clara County, and I will invite Oliver and Allison to join us now.
Thank you, Autumn. Hi, yeah, my name is Oliver. I'm one of the assistant directors of pharmacy for the County of Santa Clara, overseeing Custody Health Pharmacy. And I will hand it over to Allison Mai, who is a supervising pharmacist for Custody Health Pharmacy.
Thank you, Oliver. Hello, everybody. I am the current supervising pharmacist for our Custody Health Pharmacy, and Santa Clara County has created a few slides to just provide some information on our process since we have gone live October 1. Next slide, please. Okay, so just a brief overview on our County of Santa Clara health system. So within our health system, it includes our Santa Clara Valley Healthcare, which includes Custody Health. Additionally, we have 3 hospitals, as well as our health centers and outpatient clinics. Part of that are our outpatient pharmacy locations as well. Next slide, please. So our Custody Health system is made up of 4 different facilities. We have 2 of our adult custody facilities, Main Jail as well as Elmwood, and then we have 2 of our juvenile facilities, Juvenile Hall and William F. James Ranch. Next slide, please. So our custody pharmacy is an off-site outpatient pharmacy, and our single pharmacy provides medications and services to all 4 of the facilities. Additionally, we have a network of our outpatient pharmacies, and they play a pivotal role in assisting in medications in hand as well as our discharge medications. And our system is the Epic EHR software, and currently for Custody Health, we utilize the Epic Inpatient module. Next slide. Okay, first item to discuss is just about the 90-day pre-release services. So we are utilizing a retrospective batch billing workflow. And I've listed the tools that we are currently utilizing in order to do this retrospective batch billing. First, we have our CalAIM reporting workbench. So this is actually a workbench in Epic where it pulls all of the JI eligible patients who have been discharged. Since we are doing a retrospective batch billing, we're looking to see which patients are eligible once they are released, and then we're looking 90 days for the pre-release services. Next, we have Willow Ambulatory. Currently, right now, we're not able to have the custody or the CalAIM custody JI billing uploaded automatically. So we use Willow Ambulatory to go in and manually update the patient's insurance to contain that custody JI insurance plan. Next, we have an adjudication queue. And so this queue actually is collecting all of the medication administrations for patients that are incarcerated. This includes patients that are not necessarily JI eligible. So we are using this adjudication queue to do the claims, but we are referencing our CalAIM reporting workbench to identify which patients are actually eligible. Next slide, please. Okay. So here is a screenshot of what our CalAIM reporting workbench looks like. So as you can see, it pulls in patients that were JI eligible and have been released. It provides a MRN, and also not included in this screenshot, it also provides the Medi-Cal aid code. And so we actually use that Medi-Cal aid code when we are updating the insurance in Willow Ambulatory as well. Key components for this report is identification of our KOP medications. We also have columns for if this patient received medications in hand. And some really helpful columns for pharmacy adjudication is the claim status. So as we are adjudicating, we are putting a status of either currently in progress if there are items that we need to come back to and resolve, or if we have completed it, we have completed it, and we can also put additional comments as well. Next slide, please. The other tool we use is the adjudication queue. So as you can see with the patient, you can put the patient's MRN, which you pull from the CalAIM workbench report. It'll bring up all of the administrations for this patient. And then we're able to go into each of those medications, review it for appropriateness, and then adjudicate that claim. Next slide. So as of October 1st up until December 6th, we have adjudicated about 92 claims. 67 of those claims went through and were paid, and 25 claims were rejected due to various reasons. In total, we have about $4,500 in total reimbursements. And just to highlight, these are not all of the billable claims. These are just the claims that we have had the opportunity to adjudicate. We're currently working on operationalizing this with our current staff. So this is a reflection of numbers from adjudications that myself and Oliver have manually done. Next slide, please. Useful tools is I found that the NDC list, Excel list has been very helpful as I'm doing the adjudications. Typically when I'm going into each of the medications, I'm cross-referencing the NDC that was used on that claim and looking at the Excel to see if it is a Medi-Cal approved NDC before I try to submit that claim. We also have the Medi-Cal RX diagnosis crosswalk, which we have been referencing to identify medications that require that diagnosis code. Next slide. So some challenges that we've encountered related to the 90-day pre-release is just related to using the inpatient EHR module to facilitate our outpatient billing. An example of that is having to manually input the insurance into Willow Ambulatory. Since we're using that inpatient module for the adjudication queue as well as when orders are placed, it's not communicating necessarily to that Willow Ambulatory outpatient side, so it requires that manual input of the insurance. Also, just the nature of having to manually adjudicate the queue. So we can only adjudicate as many claims as we have the time to, since it does take some time. And then some issues that we've come across related to rejected claims include NDC not covered. So some of our medications are on the CDL, but the specific NDC that we had used was not covered, and therefore we're unable to bill for it. Another issue that we have encountered is just medications that require prior authorizations. We haven't encountered many of these yet, but they're just a handful of medications that we have not been able to adjudicate due to the prior authorizations. And then lastly, I mentioned for the adjudication queue, it's pulling all of the medications that are administered. And so we do have a keep on person medication program. And for these medications, they're not actually documented as administered in our EHR. They have their own special indication that the medications were given to the patient and the patient has them on hand. So as of right now, we haven't been able to bill for those medications that are keep on person, but we are working to identify a way to be able to bill for these medications. Next slide. Okay. Next item is related to medications in hand upon release. So we have developed a care coordination and discharge planning team, which has been working very closely with the pharmacy team in order to have a successful process and getting medications in hand when the patient is released. So the workflow for this is the CCDP team will first verify that the prescriptions have been sent by the provider and that they are ready to be filled. Then they will notify the pharmacy, usually via email with a list of patients that have prescriptions that are ready to be filled. And then they also call the pharmacy as well to notify the pharmacist that is working at that pharmacy. We have one designated pharmacy that the pharmacists or that the providers have been writing the prescriptions to, but we have a alternative pharmacy as well when the primary pharmacy is not in operation. Following that, the medications are prepared at the pharmacy, and typically the CCDP team will notify the pharmacy of when they're planning to pick it up. That way the pharmacy can assess how much time that they have in triage as necessary. Before CCDP comes to the pharmacy, they'll call just to confirm that they can pick it up and then coordinate with the pharmacy team upon delivery. And once they pick up from the pharmacy, they go to the facility, and we have locked cabinets in the facility where the medications are placed. And then when the patient is released, a medical unit clerk at the facility will get the medications from the locked cabinet and put it into the hands of the patient that is being released. Next slide. So some challenges that we have faced regarding meds in hand is just short turnaround time. For some medications that the pharmacy does not have in stock, we do utilize central fill to help. But of course, when there are short turnaround times, it is difficult if central fill is inundated with orders as well. Next is coordinating with program releases. We do have some patients that are released to specific programs, and in those scenarios, we wouldn't necessarily do medications in hand. Instead, we coordinate with the programs to make sure medications get to the facility, and then that facility will be responsible for getting the medications to the patients. And then lastly, we've been doing medications in hand specifically for patients with plan release dates. We are still working on identifying the best practice for unplanned releases, but as many of you may know, it's very difficult to predict when some of these patients may be released. Next slide. For future state, we are working on being able to do an auto adjudication. And so part of that is the adjudication queue also collecting both administrations and dispenses. If we're able to collect dispenses, we'll be able to process the keep on person orders. So currently working on the infrastructure for that. And then lastly, we are currently onboarding a transition of care pharmacist. This pharmacist will be helping on both ends. So we have a pharmacist that will be helping with the medication reconciliation at intake and admission. And then we would have another pharmacist sitting on the discharge end, helping with discharge medication reconciliation and helping providers write those orders for patients that need to be released. Next slide.
All right. Thank you so much, Allison and Oliver. Wanted to maybe start off the discussion going back to your last slide, actually, on the future state. You talked about some of the challenges and current strategies that you all have in place around like manual entry. So the automation of processes sounds like probably a good idea and things that maybe other counties want to be thinking about. Can you talk a little bit more detailed about kind of some of the steps that you took to test different strategies that led you to kind of make decisions about your future state priorities? Like how did you determine that those are the right like next actions, particularly like the transition of care pharmacist, or is it just it's some of these other pieces around the adjudication queue, and is it just trial and error? Did you test within your system? What are kind of the things that led you to move in this direction?
Yeah, I can talk a little bit about the transition of care pharmacists. For specifically medications in hand, prior to our go live, we did test out this workflow several times. We had several different pilots with the CCDP team and the pharmacy team. And I think one thing we identified was even if patients had or even if patients were taking medications while incarcerated, providers didn't have the necessary resources and time to write prescriptions for every single patient. So because we are part of a large health system and we have our other hospital systems, we looked to see how transitions of care was working on the inpatient side as well. And currently we do have transition of care pharmacists in the inpatient side. So we looked at their model and to see what we could use on the custody end. And one of those things that we identified was being able to have a pharmacist help providers write these discharge prescriptions for patients in order to increase the prescriptions that are being sent at discharge.
Hey, this is Oliver. I'll touch upon the adjudication queue as well. This is actually a brand new tool that Epic created for us. We were told it's the first time anyone's ever pursued something like this where we're adjudicating outpatient claims using the inpatient module. But because our pharmacy staff use inpatient module on a daily basis, we did want to keep everything in the inpatient module as much as possible. Aside from the insurance information that Allison mentioned, that unfortunately wasn't able to cross over. So because it's so brand new, when Epic first came to us, the decision had to be made. We can only collect all administrations or all dispenses. And so we decided for the initial go live to only look at administrations, just because that would ensure that whatever we're billing, we have documentation that it was given to the patient. If we just did dispenses, a lot of the times we dispense and then we get medications that come back. And how do you reliably track what comes back and how to rebill patients, things like that. So going with administration, just like in the inpatient side, when you charge on admin, it's a more conservative but more accurate approach for billing. But we did request a future development to also capture dispenses. And the way that our KOP system works is we actually dispense from, physically it's the same pharmacy, but virtually it's a different pharmacy. So our plan is our KOP pharmacy dispenses will flow into this adjudication queue. And like Allison mentioned, we'll be able to adjudicate from that, along with our pill call administrations that we're doing today. In terms of auto adjudication, well, it does take a lot of time. I remember when we first started the queue, it took like an hour to do like three claims or something like that. So it's still something that we're learning and fine tuning. But to make this make sense from a financial perspective, there should be some level of auto adjudication to help us out with this process.
Great, thank you. Super helpful. We do have a few questions in the Q&A that were sent in for you all directly. So answer what you can, and we'll take back anything. So feel free to say pass, take back anything that you don't want to answer live. I think this first one we already know the answer to, but I'll just read it out. Are you manually updating the JI aid code in the workbench, or are you able to pull from, the question says meds or the portal? I think the answer is it's manually at this point.
Hi,
Yeah.
Michelle
Oh,
here.
yes.
I don't know if you want me to take that one.
Go for it,
And
Michelle,
we
please.
are manually entering into our Epic system the JI aid code at this point. Yeah.
Yeah, great. I figured that would be the answer given everything that you've shared with us so far, but thank you. There's another question about the JI Epic report standard and or the Epic report, and whether that's standard in all Epic inpatient modules or if it's a custom report built by Santa Clara County. And a follow-up question about how you're pulling in the discharge date and time and the JI code status. So it sounds like how you're doing it is manual entry, but is
Yeah.
it a custom report that you all built?
Correct. Yes, it is a custom report that we have built. So I honestly am not sure how those fields get populated. We have a wonderful Epic analyst. Her name is Fatima, who is able to do these magical things with Epic for us. But she created the report and was able to pull the fields for like JI code status and discharge date, and was even able, those two fields that Allison mentioned that were helpful in terms of documenting our progress. That was also a customization that we added later on, just to help us keep track of our work and making sure that we know who we completed adjudication and who we still need to work on.
Great.
The only thing I would add
oh.
on that is the discharge date is fed to our health record from the criminal justice component when that is in the system. So that's where that comes from. It comes from the court, the criminal justice center. In the juvenile setting, we have somebody manually entering the discharge date when we get that communicated from juvenile probation.
Okay, great. Michelle, this one might be for you, actually. Just wondering a little bit about, I know we've talked in our one-on-one meetings with you all about some of your successes around the meds in hand piece. I'm wondering if you want to share anything about kind of some of the testing strategies that you all came up with before you went live, and as you were over the last, couple of months, as you've been working through the process to get to something feasible and workable for Santa Clara County. What are your lessons learned there?
Keep at it, keep trying and keep testing. I would say we are in a good place based on the testing and the work we've done on those with planned release dates. Our unplanned releases are still not solved for. So unplanned releases, we're looking at pulling in court dates as some information, but then also linking that to what type of court it is. So not necessarily related to any charge information or any specifics on that. And then also we have built a field for possible release date with a source of that possible release date, so that in case conferencing, we can pull in that information if we get it from, say, the public defender's office or from the patient or from the other attorneys in the work or on a programmed release. So when we get that additional information, that will help guide us on planning for those releases. In our correctional facility, we have behavioral health meds and non-behavioral health meds. So ensuring that we have identified those meds that are needed for release so that we can quickly pull a list together that needs to get reconciled and ordered and to the pharmacy, so the pharmacy has time to prepare that. Testing that and getting that earlier where possible is really important so that you don't end up stressing the entire system, rushing through to get all the information available in that process. And we piloted with our behavioral health and non-behavioral health prescribers prior to going live on a day or two, just a 1 day or 2 day test to see how to make that happen. So those were some of the things that we did before to really try and do the meds in hand component. And it's a lot of moving parts to kind of coordinate together. So I just strongly recommend testing.
Great, thanks, Michelle. We do too. I think it's such a good idea as we're figuring out how to implement this initiative across the state to test different strategies. And that's why it's a demonstration initiative, by the way, so we can figure out what works and what doesn't work. So appreciate you all sharing your experiences in Santa Clara County. Just 2 more questions. But before we get to the last questions, just want to flag that we did get a further response from Fatima about the EPIC report. So I'll just read that out so that everybody has the information. It is in the Q&A if you'd also like to take a look at it. But Fatima says that the JI EPIC report was created from a standard EPIC reporting workbench template, but the columns that display the data are customized and pull from a custom form that is manually being updated from staff into the electronic health record based on information they manually enter into the JI portal. And so there's the answer from Fatima. Hopefully that's helpful. And for the Santa Clara team, I just have 2 kind of bigger questions, I guess. What 2 months in do you wish you knew before you went live about this program that might be helpful? And then what is the kind of biggest piece of advice that you have for your county and state colleagues who are preparing to go live?
I would say maybe for both your questions, Autumn, is that the Medi-Cal and insure and all the rules and regulations, there's a lot that we've had to learn. But we're lucky in the sense that we're part of the County of Santa Clara. So we have a vast network of almost 20 outpatient pharmacies who are also already contracted with Medi-Cal. And they live and breathe this stuff every day in terms of what's covered, prior authorizations, and troubleshooting like override codes and things like that. And so we've had to lean pretty heavily on them when building out these processes and double checking with them on what makes sense, what works, what's allowed by Medi-Cal. And so I think it's really important that you have you recruit a colleague or somebody who has that experience on the outpatient side to help guide you through all the rules and regulations. That because we're lucky to have that already within our health system, but we had to reach out to a few individuals pretty frequently to gauge their expertise on how to bill for some of these things.
So partnership seems to be the key to success.
Yes, reaching out to, instead of trying to navigate something that you're not familiar with, try to recruit somebody who does this and is an expert on it. It was so helpful to have that consultation available to us.
Excellent. Anything you want to add, Allison or Michelle?
Allison, go ahead, and then I have one final note.
Yeah, I think just to echo what Oliver has already said, partnership is really important. One thing I found really helpful is leading up to our go live, we had meetings every week, maybe multiple times during the week with all of our stakeholders to make sure we were on the same page. And as we've gone live, we still continue to meet on a regular basis to update the team on our processes and initiatives, and also just to be able to understand some of the issues that are occurring in other areas. So having those regular meetings have been really helpful as well.
Great. Michelle?
And one thing that I think was really valuable was when we had our initial go live, especially around medications. In the custody setting, a lot of the over the counters are prescribed, and we had turned on a function where you have to associate diagnosis with every medication that was ordered to capture those things. And we found out quickly that in the custody setting, because we're in the inpatient module, it was incredibly overwhelming for the providers. And so just listen to your providers when you're going live with these things. Listen to the team that's doing the work on the ground, because you don't want to overburden them where it's not necessary. Because when we took a step back and looked at the number of medications that actually required a direct diagnosis association, it was smaller, and we were able to decrease the burden on the providers significantly by taking a step back and looking a little bit deeper at that. And so listen to your teams. They are doing the work on the daily, and whatever you can do to decrease the burden, because their jobs are already really super duper hard. And so making it as easy as possible for that frontline staff to do the right thing and make it easy for them wherever possible was really important for us, and we're continuing to try to do that every day, because we know this is a big lift for them as well.
Thank you all so much. It is a big lift. It's a big lift for all of us, I think. But we are here to work together, to collaborate with you all, help answer your questions. Thank you again and again to Santa Clara County for continuing to come and share your story of how this is working in Santa Clara. I know that it's still new for you, but I find it to be invaluable information to share out with your colleagues from across the state. And we're looking forward to continuing to watch and see how things evolve and grow in Santa Clara County. Also, just as we're wrapping up for today, a little early, want to give a shout out to the Yuba County team, to the Inyo team, to all of the other county folks that we've worked closely with over the last couple of years and at launch, and those of you who have generously given your time to this Learning Collaborative series over these last 4 months. It's better for all of us, including us at DHCS, when we learn together, when we hear from you all. It helps us to make the program better and more manageable. So I really appreciate all of the insights that you've all shared with us, and looking forward to continuing the conversation. So as I said at the beginning, today is the last of our scheduled Learning Collaborative series meetings. And on the next slide, you see the series. We will have an office hours meeting next week in case folks have follow-up questions or would like to bring additional thoughts to that meeting. And then we're going to take a break for the rest of 2024 and continue on in 2025. So we have some thoughts on topics that might be helpful. We're also going to be sending you a survey to seek out your input on what topics we should prioritize for 2025. So please look out for that survey. We're really looking to hear from you so that we can not only understand what worked or what didn't work for you as part of this Learning Collaborative series, but how we can bring additional information that would help support you all in implementing this initiative across the state. We also have a couple of counties that are still in the queue to go live in January, pending approval, final approval of their readiness review applications. We know CDCR is going to go live in February, so really exciting things are going to be happening in the new year in 2025, and we'll just continue to learn from each other and grow through not only this series, but through all of our efforts to implement the Reentry Initiative across the state. So again, thank you all for joining us today, for all of the time that you've spent in these Learning Collaborative sessions. Please submit your office hours questions to our CalAIM advisory group email for next week so that we can be prepared with some responses that'll be most beneficial to you. Anything that we didn't address in the Q&A today, we'll bring back to the office hours session for next week. And I hope that you all have a wonderful holiday season, however you celebrate. Even if you don't celebrate and you're just going to take some time to be quiet and reflect and enjoy life at the end of 2024. Hope that's what you're planning to do. And we'll look forward to continuing our partnership in 2025 with all of you. Appreciate you all so much. Have a wonderful day, and we'll talk next week. Thank you.